Sure. So the ARAMON trial was a phase II single-arm clinical trial in terms of the lead-in phase. We were looking at darolutamide monotherapy in patients with essentially biochemically recurrent prostate cancer. So the primary endpoint of this study was looking at the testosterone levels, serum testosterone levels at 12 weeks on therapy. None of the patients received any androgen deprivation therapy. And really the background for this study was that darolutamide is a pretty structurally different AR antagonist from the other AR antagonists out there. And there's been preclinical data and early clinical data to suggest that there's less penetration across the blood-brain barrier, potentially leading to less activation or increase of testosterone production. And that may lead to a better side effect profile. And so with this trial, it was a small lead-in trial, lead-in phase of the trial that we presented. 24 patients, all with biochemically recurrent prostate cancer with fewer than 5 PSMA PET detected lesions. And they received darolutamide monotherapy. And what we saw was that at 12 weeks of therapy, the testosterone levels increased in the serum by about 53%. So that, I would say, is a relatively modest increase in serum testosterone levels relative to what we know with other second-generation AR antagonists. We saw that there was still feminizing, what we term feminizing treatment-emergent adverse events, gynecomastia, breast or nipple tenderness or pain. And I think that probably speaks to some potentially base level of increase in serum testosterone that might translate over to peripheral conversion into estrogens and leading to those side effects. I think in terms of other toxicities like fatigue, we actually saw, I would say, a relatively low amount of fatigue, mostly grade 1, 2. And in terms of other side effects, again, relatively little and grade 1 to 2 mostly.